In a patient who has esotropia and limited abduction of one or both eyes, the examiner should suspect sixth nerve palsy, but a differential diagnosis is always mandated. Congenital sixth nerve palsy occurs infrequently. On further testing, most apparent sixth nerve palsy in infants is found to be pseudo-abducens paralysis. Acquired sixth nerve palsy is more common and is usually self-limiting. The doll's head or the oculocephalic maneuver confirms the presence or absence of a full abduction in infants. If the infants show a full abduction in doll's head maneuver, the diagnosis of pseudo-abducens palsy is reported. This occurs in cases of essential infantile esotropia and in cases of nystagmus compensation syndrome or nystagmus blockage syndrome. The differential diagnosis of sixth nerve palsy in infants with limited abduction with doll's head maneuver are Duane syndrome type 1 and type 3, where there is limitation of abduction, and also it occurs in Mobius syndrome, which is characterized by bilateral sixth nerve palsy and bilateral facial paralysis. In cases of acquired limitation of abduction, we have to do a force abduction test. If the force abduction test is positive, we estimate the generated muscle force. If it is reduced, we suspect the presence of chronic sixth nerve palsy or sixth nerve paralysis. But if the generated muscle force is normal, the differential diagnosis is tight medial rectus from previous over resection of this muscle. If the force abduction test is negative and the generated muscle force is reduced, this is definitely acute sixth nerve palsy.